I'm afraid that there's really no good or positive way for me to start my remarks to you today. This is because earlier this week on Tuesday, an absolutely devastating report was released using data from the Chief Coroner's Office of Ontario. It examined overdose deaths during the first 4 months of COVID from March until the end of June, and it shows a devastating 38% increase in overdose deaths in those 4 months above pre-COVID levels. Now, these numbers, unfortunately, won't be a surprise to anybody who's been working on the front lines, who've been trying to cope with the fallout of the continuous deaths for years now, and who've been struggling to cope with the massive increase in overdoses that we've been seeing since the beginning of the pandemic. This report also predicts that Ontario will see almost 2,300 deaths from overdose in 2020. Now, just to contextualize this for a moment, Ontario saw 1,500 deaths in 2019. And there were 3,800 deaths across Canada that same year. I have to admit that I'm having trouble comprehending 2,300 deaths in Ontario in 1 year from overdose, because I thought it was bad last year when we had 1,500 deaths. The silence from the provincial government on this issue right now is absolutely notable. Our Premier, our Minister of Health, no one has commented on this report since it was released. They haven't mentioned it. There's been no announcements of emergency funding. There's been no condolences to family. This is shocking, but perhaps not surprising to anybody who's watched their continuous ignorance and mismanagement of the overdose crisis since taking office in 2018. They have never, to my knowledge, even acknowledged when we hit 1,500 deaths last year. They've not talked about the enormous loss and collective trauma that these numbers represent for families and communities across Ontario. The silence from all levels of government is not just disrespectful to families and communities, but it feels incredibly violent to people on the front lines of the overdose crisis right now. It's absolutely shocking to me that in the face of these new statistics that confirm what frontline workers have been desperately trying to tell us, what they've been desperately trying to call attention to since the beginning of the COVID pandemic, and in fact, for years now, we're being faced with absolute silence and a lack of action. There's currently no one in charge of the overdose response in Ontario. There's no coordination. When communities tell us that they're in absolute despair because they feel like they've been abandoned in the face of a crisis by all levels of government, they're right. They have been abandoned. They've been already abandoned even prior to COVID, but COVID has made this infinitely worse. Now, there's a few reasons why I think that COVID has been particularly disastrous for people who use drugs. The first is our long societal neglect of the social determinants of health, particularly affordable housing and adequate income supports. We've seen our social safety net wither away over the last decades with repeated austerity budgets by all levels of government. The full impacts of decades of underinvestment in affordable housing and in a total lack of investment in new social housing options was apparent even prior to COVID, when, for example, we had about 10,000 people every night in Toronto who were homeless, unsheltered, or using the shelter system, every single night. And indeed, the new data that we have from the Chief Coroner's Office shows us that from Toronto in the last year, a full 25% of all overdose deaths are in people experiencing homelessness. Now, while COVID has shined a little bit of light on the homelessness emergency, as it can be seen so visibly across the country in the encampments that have been popping up in parks and green spaces, physical distancing within shelters has cut the number of beds available. And this, coupled with the early outbreaks in the shelter system, meant that people did not feel safe in those congregate settings when COVID could spread so easily. And they were right. People who had been couch surfing were left with nowhere to go, as everyone told them to isolate and reduce social contacts to limit COVID spread. I think that one of the lessons we need to learn from COVID is that risk is not distributed evenly among all our community members. This is partly due to the social determinants of health, but it's also partly due to the way the experience of risk is structured differently for people in different social positions. You can see this in Toronto's COVID numbers, where poor people and racialized community members are disproportionately impacted by COVID, with vastly higher infection rates. We need to refocus our attentions on ensuring an adequate income for everyone. Our OW and ODSP rates should be an embarrassment. No one can live on them, and we shouldn't be expecting people to. We need a living income for everybody with no exceptions. Access to safe, affordable housing is a basic human right. And while COVID has led to renewed attention to this issue, I worry that we're not focusing enough on the need for immediate and sustained support to repair, build, and increase the stock of affordable housing in big and small communities across the country. But let me back up for a moment and tell you a few things that I think were done well in the COVID response. In the early days of the pandemic in April, I was part of a team in Toronto that quickly led a consultation on how to provide a COVID isolation and recovery site for people experiencing homelessness and diagnosed with COVID. This was at a point where we were beginning to see outbreaks of COVID within the shelter system, outbreaks which were due in part to years of chronic underfunding and neglect within these spaces. The first plan was to use the Better Living Centre, which is a very large exhibition hall, as a form of field hospital for people who were not sick enough to need hospitalization, but needed a place to isolate for 14 days and weren't able to isolate in their homes because, quite simply, they didn't have homes. We quickly consulted with community organizations with expertise in sheltering people experiencing homelessness, with expertise in harm reduction, with expertise with people with mental health challenges. And we heard that people needed dignified sheltering options, including private rooms with private bathrooms. The voices in our community consultations strongly advised that sheltering people within COVID in congregate settings like the Better Living Centre was completely unacceptable, was undignified, and that hotels with integrated teams on site should be the option pursued. And it was. And I think this was a massive win because with the hotel model that emerged, while it was not perfect in any sense, it had several strengths. The major strength was the presence of 3 integrated care teams on site, including a medical and nursing team, a community team that included harm reduction workers, and peer teams that included people with lived and living experience of homelessness and drug use. An overdose prevention site was eventually opened on site at the COVID Recovery Hotel as well, and safer supply was prescribed to people, including both opioids and stimulants, to ensure that people could isolate without experiencing withdrawal. A managed alcohol program was also provided to people on site. Now, the COVID Recovery Hotel model in Toronto is one example of harm reduction innovation that we've seen in this pandemic, where a strong community consultation and partnerships led to the development of a model for providing on-site integrated care with teams of people with lived experience, community workers and harm reduction teams, and medical care, all integrated and provided on site 24 hours a day. Now, I'd like to contrast this to the situation in shelters and respites, where in 2020, 4 years into a deadly overdose crisis in Toronto, we still don't have a single overdose prevention site open in a shelter or respite setting in Toronto. As part of the COVID response measures, physical distancing hotels were also opened in Toronto, both to relieve pressure on shelters and to provide space for people to move into from encampments. But these hotels had no overdose prevention sites, very strange rules on what you could use on site and couldn't that varied by site, and inadequate access to harm reduction supports. Predictably, people have been dying for years now of overdoses within these hotels. And this is not a shock since people have also been dying for years now of overdoses in shelter bathrooms across the city. We've traumatized an entire generation of frontline workers by leaving them to repeatedly pull people who are blue and not breathing out of toilets to try desperately to revive them, rather than providing basic supports on site for overdose prevention and response. Now, I just want to pause here and highlight how we have no supports for all of the frontline workers who are trying to work amidst all the trauma, grief, and loss that this overdose crisis has caused. I've never seen people as burned out and traumatized as they are right now. It feels like we're abandoning them. This abandonment is all the worse because, and I really need to emphasize this, frontline workers were absolute heroes in the early days of the COVID pandemic. The shelter workers who showed up to work with no PPE when they knew that they needed it. The harm reduction workers within overdose prevention sites, supervised consumption sites, and harm reduction outreach programs who knew they couldn't close down services because of the continuing overdose crisis. So they quickly adapted and innovated and figured out how to keep their services open. They were already overworked and underpaid and burned out, and then they doubled down. This is a phenomenal accomplishment and it really needs to be highlighted, but not just with words that are empty words of praise, but with actual supports, with funding, with trauma-informed counseling and care. I spent the last 2 months working on a project with the Centre of Drug Policy Evaluation here in Toronto, looking at harm reduction service access during COVID. And while our results are very initial, what we found is that for many people, their access to harm reduction services, including supervised injection sites, and overdose prevention sites was mostly very good. They reported increased wait times. They reported that sites had to move them through a little bit faster in order to prevent long lines from forming. But generally, people were still able to get access to both harm reduction supplies and supervised consumption sites. Now, I should note here that we conducted interviews in the supervised consumption sites where service continued throughout the pandemic. It's very notable that Toronto's largest supervised consumption site shut down for several weeks early on in the pandemic, and that when they reopened, they instituted an appointment-based system that has undoubtedly resulted in major access issues. However, while people reported that their access to harm reduction services has remained good, it's very notable that people reported major barriers to access to other services, notably shelter and food. I had people tell me that they lost 25 pounds because they had nowhere to go to get food during the early days of the pandemic, because they could no longer panhandle for money to feed themselves during those early days as well. So what can we learn from all of this? So I think it's very important to note that harm reduction service access and innovation had been stifled in the period leading up to the pandemic. Harm reduction service access saw a really large increase in the period of 2017 and early 2018. We saw overdose prevention sites open across the province very quickly. But unfortunately, this has been stagnant since the Conservatives took power in 2018. They've actually reduced the number of funded funded supervised consumption sites since coming into office, and only one new site has been improved and opened since they took office, despite increasing overdose deaths every year in this province. The other thing that I'll note is that there are evidence-based treatment options that we are not currently using in Ontario because the government refuses to fund them. This includes injectable opioid agonist treatment options that would either use diacetylmorphine, which is heroin, or injectable hydromorphone. We've been asking repeatedly for these options to be covered so that we can start offering them within our communities, and we've had no response at all from the province. We also need to rapidly be scaling up safer supply programs in Ontario. We've been able to do this through short-term funding from the federal government, but most of this funding is set to run out in March of 2021 in just a few months. And I will look into my crystal ball here and predict that in March 2021, we'll be in a really, really bad state because of the confluence of winter, the overdose crisis, and the pandemic. And so we need to have further supports to continue the safer supply programs that have already started and to increase access to them across the province. We're heading right now into what will be a very bad winter. Every year, people working with people experiencing homelessness tell us that we don't have enough spaces for everyone. Every year, they're ignored, and this leads us to a predictable crisis every single winter. I want to highlight as well that we could do better, we can be doing better, and we're choosing not to. I referenced the evaluation, the consultation that I did that chose not to open a COVID recovery site at the Better Living Centre because our community consultation told us that this was an undignified option for sheltering people. Well, the Better Living Centre opened a week and a half ago as a respite centre. And this was, again, the very place where our consultation this spring had told us resoundingly that we should not be opening a space. And as a supposed move to prevent COVID transmission, they've built glass boxes around the beds for the people who were going to be living there for the winter. Now, I can't shake the fact that there was time to build glass boxes for people at the Better Living Centre, but not to build robust overdose prevention sites or harm reduction services on site into the model. This, despite an absolute crisis of overdose deaths that's been going on for years now. There's no magic solution to the crisis that we're now in. But a very good place to start would be to stop building glass boxes and to start listening to frontline workers and people with lived and living experience. They've been telling us for years what they need, and we just haven't been listening. Thank you very much, and I'll be happy to take questions after the other panelists present.
Thank you very much, Gillian, for that clear account of what was happening in Toronto and the analysis and the passion that you bring to this. I'd now like to introduce Callie Lathem, and Callie is a harm reduction worker and health promoter at the Somerset West Community Health Centre in Ottawa.
Hi, everyone, and thanks, Gillian, for your comments. They really resonate with me as a frontline worker, and having lost a client this past weekend, I think that your points really hit home. The bad news and the tragedy just keeps on coming. I want to start by saying thanks so much for having me here and giving me the opportunity to talk about the amazing work of food security that I've been able to witness in the community. As I talk about my observations, I want the audience to know and to think about the wonderful people who have done and supported this work and the connection and nourishment it has brought to the community. This is a widespread team effort, and I'm so grateful to everyone involved. I come to this presentation as a person with a roof over my head, food in my fridge, and significant earned and unearned privilege, and that has an impact on the way that I talk about food. I use language like food security, and as a worker in this field, it's language that I hear often. What I want to make clear is that these words are diluted and palatable ways of saying hungry, no place to be, isolated, and often excluded. And I clarify this to ensure that I'm respecting and honoring the experience of the people that I get to learn from and work with and serve every day. It can be hard to center hunger as a priority in the tragedies of the multiple intersections of the overdose crisis, the homelessness crisis, and the pandemic. The intensity and urgency of keeping people alive can really minimize the other social determinants of health. I want us to start by just thinking about what we are capable of doing when we're hungry and how much your hunger impacts you. Food security has replaced the term hunger, which elicits a much more visceral understanding of the pain and turmoil that hunger and not having enough food every single day has. I work at Somerset West Community Health Center, and we are a community health center with many community-based programs, including harm reduction programs. And by default, we have branched into food programming, not because it necessarily fits our mandate, but because most of our clients struggle to get enough to eat. My time here feels like an opportunity to highlight and challenge the ideas we have of food security and put more emphasis on foods as a mean of harm reduction. I'm going to discuss what we know about people who use drugs and food security, what food programming looked like pre-COVID, food programming during COVID, gaps in this topic area, what I have observed, and what I have learned. So people who use drugs are disproportionately affected by food insecurity. Research has shown that 65% of people who inject drugs in urban Canada reported difficulties in affording food and in experiencing hunger. We see increased negative consequences of food insecurity when people who use drugs experience comorbidities like homelessness, mental health issues, physical illness. In some aspects, we can physically see, such as weight loss, like Gillian mentioned, of the accounts of losing 25 pounds during COVID, and other consequences, such as reduced ability to fight off infection and illness, are less visible, but so impactful. This feels especially prudent during a global pandemic when we place expectations on the individual to do their part, while also not giving people access to basic needs to survive, let alone be well enough to fight off an infectious illness. Many people who use drugs are struggling to survive, and they do not have their basic needs met, and somehow we expect people to look after themselves during this extraordinary time. I can attest to the impact that inadequate nutrition, not just not enough, but not nutritionally dense food plays in mental health and in healing time. And when discussing food, we need to focus on the social, psychological, and soul impacts of not having a place to eat with community, not having enough to eat, not having choice in what you eat, and all of these factors are amplified in the context of the global pandemic. Before I get more into discussing our response to community hunger during COVID-19, I want to discuss a bit about food security programming at Somerset West pre-COVID. So previous to the global pandemic, our food programming was sporadic at best. Ottawa, like our center has wraparound services in wide-ranging areas, and we had very little food programming that was focused solely on giving out food or distributing food, especially that of which was prepared. People do not have roofs over their head, let alone stoves or places to cook food, so food banks often are not a good fit. We would have food basically when we had it. Staff would bring in a pot of soup to share with clients at the drop-in, or when someone rescued donuts or Timbits from a local coffee shop. The food programming was technically mission drift for us. However, as I'm sure most people can relate, when we see and we hear about people being hungry every single day, we all feel motivated to get food to people in any way that we can. Food is one of our most basic needs and a critical component to the social determinants of health. And for everyone, the availability and accessibility of food resources is a necessary component to our ability to live. In my mind, the more we can do for people in one place, the ways that we can shrink the daily geography of survival, or the less time that they have to travel to 5 or 6 different places to get their daily needs met, the better. Arwen McKechnie is one of my colleagues who spearheaded a major shift for us by cultivating a partnership with our food bank. We would get a weekly shipment of food that was always a surprise, and then we would rally whoever had time and space in their day and maybe a little bit of culinary skills to make something to try and serve at least one meal. A community member who came in for coffee in the morning and I began talking, and his name is David. And David is an astounding cook with years of experience in many kitchens and a passion for spreading love through food. David then began as our weekend cook, and the weekends were where we often experienced our largest gap in food access. Our partner organizations are shut, and Saturday and Sunday, there's this huge gap where there's no place to be, no place to get coffee, and no food. So David used one of the kitchens we had on site to prepare some of the most creative and delicious meals I've had. There'd be weeks that, depending on what we received from the food bank, David would have breakfast, lunch, dinner, and dessert made for people. And I get a little bit emotional thinking about the time, energy, and love that David put into these dishes. In the context of what we now know, it's hard to believe, and it makes me miss the days when we would have David in the main lobby of our center with his cart full of delicious food, serving people on reusable dishes that we washed at the end of each meal, and people sitting around eating and enjoying the food and company. Some people would even come to the center on the weekend asking if David was cooking that day, and they would stay around if he was. The programming that we had built to sustain people in the community was over as we knew it when COVID-19 hit. We were no longer able to serve coffee off our coffee cart, have people eat indoors, have David prepare meals for us, and it brought everything to a halt. Our community partners had to shut, meaning the family-style meals that brought people together to connect and nourish their minds, souls, and bodies were no longer available. People not only didn't have access to meals that potentially supplemented their grocery bills, allowing them to get a little bit more food to fill their bellies, people had zero access to food at all. Harm reduction services at our center were open, and more than ever, we heard how hungry people were because there was nowhere to go to eat. The barriers for food programming included many things, such as the new infection for COVID-19 that we knew or continue to know very little about. What did food preparation look like in the age of COVID? How do we keep people safe while eating? Where do people eat? And more. Our community partners pivoted their service provision in really heroic ways. A drop-in and meal program started preparing bagged lunches for people to take them, and we distributed 100 of those a day from our site, and outreach services began carrying food on them when possible to distribute to people. A new program and a shining light in the food security response during COVID-19 is called Cooking for a Cause, and this is from Parkdale Food Center and the Ottawa Community Food Partnership. And in partnership with 9 social service agencies. It's collaborated with 17 food businesses in a mutually beneficial arrangement where there are 4,000 meals cooked every week, and there's been over 70,000 meals cooked so far, and those have been distributed by 25 social service agencies. And none of this would have happened if we hadn't broken out of our bubble and looked around and saw what was possible. It was really innovative in a time where we were crisis response and crisis management. So Somerset West is connected to 3 local restaurants, and we get from Urban Element, Kowloon Grocery, and Double Happiness Barbecue 750 meals a week that we distribute on site. And Seniors Outreach and our Rooming House Outreach teams have also been able to get groceries and prepared meals to distribute to folks. In total, since we began working with this program at the end of April, we've distributed over 35,000 meals. So research shows that the relationship between drug use and poor nutritional outcomes is very well documented, but there's still very little addressing the intersection of food security and harm reduction. The programs that we have for and about food and harm reduction are often ad hoc with inadequate funding or resources, and Cooking for a Cause and our food programs that we see at Somerset West are no exception. What we do know, shocker, is that food relieves hunger. While there can be very different views on what harm reduction programming mission drift looks like, as a service provider, myself who believes deeply in the intersection of food and harm reduction, when we can spend time capturing the impacts on individuals and communities, when there's dignified, accessible, appropriate food available, we can make the case for why and how we can effectively include food programming in our harm reduction efforts. I want to acknowledge that the ultimate goal is to break and rebuild structures so that people can have enough income and access to resources, that they can get what they need and have choice in that. However, in the meantime, we also must continue to do the work that meets those needs. Regular meals and times for meals can support regular attendance to programming and harm reduction services. This is something that I've noticed. The duration of the pandemic has also caused people who were not previously food insecure to struggle with meeting their food needs. And as we continue to serve meals, people who do not otherwise have who have not otherwise accessed our programs have been coming to the center to receive food and then are able to connect with additional services. This is something that I've witnessed over months of this program running. People who I've not met before come by for a meal, and now we've been able to connect them with ID clinics, nurse practitioners, and more. Food is a beautiful and respectful invitation to other services and connection. Since providing meals regularly on site, we've had client reports of this being the best they have been fed in years, weight gain, and positive health outcomes. We've also noticed a decrease in escalation on site, and that is not a small outcome for an individual, but also for a community. So what we have learned is that this is a model that can be replicated and is far better than distributing non-perishable, nutritionally inadequate food. We know that food has a positive impact on people's health and well-being, as well as their mental health and generally the way that they feel, because there is dignity in knowing where your next meal comes from. We've been able to connect with our local business association and invest in local businesses and restaurants that contribute to the vitality, affordability, and diversity of Chinatown, where we're located. And finally, the pandemic has not taught us that food is the great connector. It has just amplified its importance to the human condition and to health, and reminded us of its power in building trust. I'm happy to answer any questions in the Q&A, and I'd also love to connect with anyone who has any ideas or projects on the intersection of food and harm reduction and hear about what you're doing.
Thank you very much, Callie, and thanks for sharing the amazing work that you guys are doing down at Somerset West. And we as well have benefited from this Cooking for a Cause and the positive impact that it's had on the people coming in to use our services has been amazing to see. I think it is going back to some of Gillian's points about the government here in Ontario, where within the CTS budgets that they've approved, they've actually specifically told us we cannot spend it on food, which we do know is a really good engagement tool and a basic human need that everybody has but certainly the folks who come in to our service have food security issues. Okay, so our third speaker on this panel is Zoë Dodd, and Zoë is the co-organizer at the Toronto Overdose Prevention Society. So over to you, Zoë.
Zoë, you're muted.
Okay, hi, sorry about that. I don't know, I'm stressed about today only because, well, not only because it's been incredibly stressful the last months. And I think anyone who's working, trying to address all the crisis we're having of homelessness, COVID, overdose crisis, it's just really taking a toll on many of us. So I'm speaking today, not just from the Toronto Overdose Prevention Society, but also in my role at South Riverdale Community Health Centre, where I've worked for the past 14 years. And I'm going to start with this quote because I think this really sums up the feelings that I have about the overdose response, the lack of overdose response. I mean, my presentation today is about how COVID has impacted both the overdose, homelessness, and COVID, all the intersections of all three of these crises, and our ability to respond. So I'm going to start with this quote, which is from Vito Rousseau, who's an AIDS activist, and this is from his speech at an ACT UP demonstration at the Department of Health and Human Services in Washington, D.C. on October 10th, 1988. Living with AIDS is like living through a war, which is happening only for those people who happen to be in the trenches. Every time a shell explodes, you look around and you discover that you've lost more of your friends, but nobody else notices. It isn't happening to them. They're walking the streets as though we weren't living through some sort of nightmare, and only you can hear the screams of the people who are dying and their cries for help. No one else seems to be noticing. I think a lot about this quote. I think a lot about his speech and about the current crisis that we're in and the overdose crisis, and how many of us have spoken up about this crisis for many years. I mean, capitalism needs a class of people that are disposable. They don't care until it affects them. Poor racialized people are the ones who are getting COVID, and poor drug users are the ones who are overdosing and dying. we tie ourselves in knots, trying to figure out the way to get them to listen to us and to act. The overdose crisis doesn't actually affect all people, and it never has, and like, that's the title of my presentation today, is like, we are not all in this together, and we never have been. Rich people don't have years of historical accumulated trauma in their bodies. Rich people don't have injuries to their bodies from working in the trades, standing at grocery checkouts for 10 hours a day. They don't have jobs that are unkind to their bodies, if they have jobs at all. And it's the same with COVID. But what we've seen with COVID was emergency teams set up, resources for free mental health supports, workplaces doing additional support like free lunches or bonuses or pandemic pay, praises for healthcare workers, constant praises to frontline workers, while people addressing the overdose crisis for the last 5 years barely hear a peep, acknowledging the hard work that people are doing. We hear colleagues at our workplaces talk about how burnt out they feel after 2 months working at home. And I'm like, well, let me tell you about the overdose crisis, the one we've been in for over 5 years. And we've leaned into a crisis because that's what we do. That's like what we know how to do. And if we didn't, the people we care about, our people, our communities will die. As our workplace closed doors to people and people had nowhere to go, tents went up across the city of Toronto, and they went up everywhere across the country, in parks, in ravines, in patches of grass. And the response to homelessness wasn't to like take care of people. It was, how do we get people out of the parks? In the first months of COVID, people were given a moratorium on evictions. But then as soon as the restrictions went down, the target of homeless people in the parks went up. It wasn't about what is the best thing that we can do for homeless people. It's like, how can we actually invisibilize homelessness? Blaming people for being in public space, but homeless people are the public. They're using public space, because if you were stranded on an island, the first thing that you would do is build a shelter. Homeless people just built shelters for themselves. And so the response has been like, get evictions, have police criminalize people for being homeless, blame them, talk about the needles in the park, anything that people can find an excuse to criminalize and target homeless people so people hate them more, has been sort of the mode of the attention. I was present for many evictions where I helped people, I was supporting people. My colleague and I, Les Harper, in March when things closed down, we didn't stop working. I've never stopped working. I haven't worked from home. I was at my job. I went outside with other workers, other harm reduction workers. We all trying to figure out what to do. We started frontline worker calls. We've had, almost 60 calls since COVID began, because we wanted to make sure that we could be there for people when services closed down around them. Les wanted to make sure that Indigenous people, he's an Indigenous man, he wanted to make sure that Indigenous people in the community were not left out. He knew that plagues and pandemics have always impacted Indigenous people, and Indigenous people, would be left to die. He didn't want to see that happen. He wanted to go outside and make sure that they were getting access to medicines, to sage, tobacco, made cedar tea for people. And we would go outside and see people on the street. We would go into the encampments to do that, to offer that to people. That was the harm reduction that he wanted to offer. I went with him as his helper. Now we've been helping Anishinaabe Health with their COVID testing van as they go into the parks and encampments and start testing people for COVID. And our job is if there's overdoses, to respond and to connect with people on the streets, because we know a lot of people. But what we've also seen is that in this goal to move people, I advocated for hotels. I wanted people to move inside. I wanted people to be protected from getting COVID. What I didn't want to see happen was people to move very far away from the town core, away from their supports, to places that didn't have any overdose death prevention strategies in place. And so people have been moved 2 hours away by transit, away from the services that they access. So people that are using supervised consumption services, overdose prevention sites as their survival, are now living so far away that doesn't have an overdose death prevention strategy, doesn't have an overdose prevention site on site, despite moving a lot of people who use fentanyl from a park into a building, because the desire and the drive to move people was more important than actually understanding their access needs and what would actually work for them. And I regret really deeply having helped move some people, one person in particular who had just been released from jail, who was overdosing quite a bit. And he moved to one of these hotels and he overdosed and died 2 days later. And I feel a sense of responsibility because I encouraged him to move. I encouraged him and I never thought about, yeah, that's great. You get to move into a hotel. It's going to be so nice. I didn't personally think about the fact that they weren't actually going to have what they needed in place for people. And you know, the very thing that causes people to come homeless in the first place is that loss of community, that isolation, that risk to their health. It's also the same factors as to what contributes to people developing habits to substances. Is that loss of community, that dislocation, that removal from land. The process of removing people from encampments is to bring police, to have a bus, to use coercion, to have eviction notices, to really bully people, in my opinion, into taking an option that they don't feel is good for them. The people in the parks have said repeatedly, I want a home. If I go into a shelter, I am just a shelter number. And so a lot of harm reduction workers have been out there trying to support people in the parks because even though the city says there's 450 people outside, the rest of us are saying there's at least 1,500 people outside, not 450. And we've been working with the Encampment Support Network because they are a group of neighbors who are on CERB, a lot of the musicians and artists. So a lot of us have been like working with them because they have been trying to stop evictions. They go in every day and offer people things that we can't offer them because we're already stretched responding to the overdose crisis, or, you know, I work in a Hep C program. We have other things to do. And it's been infuriating because we're not listening to people. You know, people who use drugs finally got to a place where they were being seen as important in a movement, as the leaders, and that's who you should consult with, until they started dying en masse. And somewhere along the way, people just thought, we don't need to consult anymore. And that's what it feels like with the encampments. Like, just move people on a bus, go somewhere they've never been, and then, you know, try to move them into a better living center with 100 people. That's not better living. So COVID doesn't apply to them, but no, because they are disposable, and so are the workers that are working there. And so that, for me, that has been the biggest issue about homelessness, is we've got a lot of money that we could be spending on permanent housing and other options, rent supplements. Like, I heard that it costs $700,000 to get the Better Living Center ready for people. There's all these workers who actually don't go in the park and engage with people and find out, like, you know, are you on a housing list? Do you have your ID? Are you ready? Yeah, and at these mass evictions, people have overdosed. I responded to an overdose at the Moss Park mass eviction. The man, honestly, I thought, like, if it'd been one more minute, that man would have been dead. And this is the thing that a lot of workers, and this will go back to that Vito Rosso quote, is that a lot of workers are finding people dead on the street. You know, the other day, someone was pulled from a porta potty. He was dead. He had his last breath in a porta potty because the city of Toronto can't be bothered to open the facilities that are in the park to the people that are there. He can't even go inside to use a toilet or take a shower in the arena or the community center. I mean, this is important because there's no dignity in this. There's no dignity in this because there's a class of people who don't care about another class of people, which are poor people. And that's who's being affected by COVID, and that's who's dying of overdose. And I just want to talk briefly about one of the other issues that we have, which is around safe supply. You know, drug users are saying, and drug users have said, needle exchange was important, overdose prevention sites are important, safe injection sites are important, and they're saying that safer supply is also important. But behind the scenes are doctors who are working to obstruct the way forward, and it's unconscionable to me. These doctors really need to reflect and think, am I being really helpful? I'll give a message to them, since they love recovery and abstinence. Take it one day at a time. Doctors could adopt this thought. Just see how it goes. Take it one day at a time. Do the next right thing. Stop obstructing and working behind the scenes to stop this life-saving intervention called safe supply or injectable heroin or whatever you want to do, and just like work in collaboration with people to help us bring that forward. Harm reduction is not about just like handing out kits to people. It's not just about making sure like a hotel program has a kit. It's actually, harm reduction is about liberation. It's about, and when I say liberation, it's about dismantling the systems of oppression. It's about being kind and loving and listening to people who use drugs, who are central to their own struggle and what they need. It's about giving land back. It's about housing and income. That is what harm reduction is about. And so there's a lot of people that are working really hard right now, and we owe a massive appreciation to them. There's a whole class of workers who are of the same class of people who are dying. They work with no benefits. They work with very limited pay. They show up every day. They're there on the front lines. They've not stopped working. And we owe a great thank you to these people who practice real mutual aid and real solidarity. The state appropriates some forms of our support, but it is the people who use drugs, people from the same class of people taking care of one another. And people are making extreme sacrifices of their own well-being. Sacrifice on their families, on their relationship, on their health, because they do not want to see people die. And so I want to thank those people who put their necks out, those who are working hard, those who are advocating at every opportunity, because we have tried all of the things. We've told our stories, we've disrupted them, we've given them silence, we've shown them everything that we can show them, and we've been abandoned in the overdose crisis. And I have so much appreciation and so much respect to the people who are showing up to stay in this fight, knowing that we're burnt out, knowing that our colleagues are not here anymore, or our own friends and family members have died. In the last weekend, I know of 4 people that died. I went to a memorial yesterday. I mean, there are memorials constantly. There are people who are dying constantly. And, you know, for some of us, we can barely get out of bed, but we're showing up. And I have so much appreciation and so much respect for those workers who are doing that right now, and people who aren't even workers, who are showing that mutual aid and support to other people who use drugs. I see you, I acknowledge you, I love you, and I thank you, because it is so bad right now. It couldn't have gotten any worse, and it did. And we know it's going to get worse, because we have been abandoned. We've really been abandoned. And that's the hardest, and like, it's very hard as someone who is a very hopeful person. I feel a deep sense of hopelessness, which I know many people are too. And I think naming it is important, and not trying to pretend that we're all positive about what's happening. But when you've watched your community be obliterated, it's not time for us to be like respectful or, you know, kind to politicians. Like I'm just like past that point. Because COVID has shown us that there's a great unequalness, and the overdose crisis showed us that for the last 5 years. They do not care if our people live or die, but we do. Thank you.
And thank you, Zoe, for that powerful presentation and sharing your insights and the analysis of what is going on and what needs to be done. I'll remind people to put your questions into the chat. Into the Q&A section. I do see that there's one there right now. This one is to Gillian, but I think it can be open to all the panelists. And what are some of the ways that these issues can be brought to the attention of government? The issues that you have raised, and that we can demand a better response to the overdose crisis.
I mean, I think that Zoe covered a lot of this over already, but I'll just echo some of the points that she's made. To be very, very frank, right now, I don't know how to make the government care about all the people that are dying. We have tried with the provincial government. We've dropped banners in Queen's Park. We planted 1,200 crosses on the lawn of Queen's Park. I've written briefing notes to the provincial government about harm reduction strategies and overdose prevention strategies. I've written more federal and provincial exemption applications for supervised consumption sites than I care to remember. I don't know at this point how to make the provincial government care. There was an absolutely shocking article that was published this week in Queen's Press Briefing, where a journalist wrote a Freedom of Access to Information Act request all communications on the overdose crisis between the Premier, the Minister of Health, and Dr. David Williams, the Chief Medical Officer of Health of Ontario, for this year. and they found zero communication at all between the Premier, the Minister of Health, and the Chief Medical Officer of Health on the overdose crisis in 2020, period. And I think that all of us who are on the ground and on the front lines knew that they didn't care, but it was just to have such a visceral reminder of it. For me, it actually kind of sunk me this week, to be honest. And so I'm not sure what we can do except elect better leaders. That would be a good place to start, I think. If you look at BC, while they don't have a perfect overdose response by any stretch of the imagination, they at least do regularly announce their overdose statistics. Their provincial government at least is regularly trying new strategies to respond to the overdose crisis. You can contrast that to the Alberta government, which was elected recently and promptly set in stage a process which led to the busiest supervised consumption site in Canada being closed, and no new sites being able to open. You can look at Saskatchewan, also with a Conservative government, where they have an overdose prevention site there that has opened, but cannot get funding from their provincial government. So there's really, I think there are nonetheless some trends that you can see in terms of certain parties and how they're responding. But it's also just not good enough. I would just highlight at the federal level that I think this year we felt like maybe there was an opening. None of us today have talked about decriminalization and the need for decriminalization of people who use drugs, and how that has to be an absolute pillar, an absolute foundational part of the response to the overdose crisis. And I personally, a lot of my research is around the impacts of criminalization on people who use drugs. And this summer, I really thought we might have an opening with the COVID crisis, and the Association of Chiefs of Police in Canada released a report arguing for decriminalization. This corresponded very nicely to several medical officers of health across the country who had also endorsed decriminalization. And we have nothing but crickets from the federal government. And worse than crickets, we have statements from Justin Trudeau saying that decriminalization is not going to be the silver bullet. Well, nobody thinks it's going to be the silver bullet, but what we would like is a wide-ranging, comprehensive response to the overdose crisis, federally, provincially, municipally, of which decriminalization could be one bit. But they're not even doing the smallest parts of it. And so I think you're probably hearing a lot of my frustrations come through. As Zoe mentioned, these have been very, very hard years, as we've tried very, very hard at all levels of government to get people to listen, to pay attention to what people who use drugs have been telling us, to what frontline workers have been telling us. For those of us who do the research, I mean, I can bring you tons of evidence-based research around the need for harm reduction, supervised consumption, for IOT programs. None of it really seems to matter. And I don't know how to make people care. And it really, really just brings, I think, to the forefront the need to start dismantling these structures that have made it so that we do have an entire class of people whose deaths are provoking no reaction whatsoever from our political and governing class.
And I think that they don't affect them because it's not their friends and family that are dying. I mean, I think that's what we got to be real about it. I remember people would say early on around the overdose crisis, they would talk about, well, it's all people. Yeah, sure. There are people who, come from upper middle class families that die, but that's actually not the 50% of unemployed people who died this year. That is not the majority of people, why places out east, why is it out east where there's like lots of, substance use? Well, that's called material deprivation. That's called like industries closing and people becoming unemployed and living in peril. Like, we also need an intersectional lens that talks about these issues of like why certain communities really struggle when there's like intergenerational trauma from colonization. That is going to make people struggle. Over incarceration of Black and Indigenous people, that makes people struggle. That affects families. The overdose crisis is also going to affect people for decades. I got interested in harm reduction and talking about overdose because the first person I loved overdosed and died when I was 21 years old. But that kind of death did not stop for me. And that's the same for lots of other people who are very committed, because we understand that. We've experienced that ourselves fully through our whole lives. We have family members, we have friends, and we're in it for a fight because we know if we don't stop fighting, more people will be dead. But there are other people who never speak out. There are other people who have positions of power who also work in our field who could also speak out more. There are doctors who are speaking out around COVID all over Twitter. They could also talk about the overdose crisis. There are people who are VPs and presidents of hospitals, CEOs of hospitals. They could talk out. And they could also speak to their own workers in their hospitals who are refusing to do safe supply and put up a poster at the St. Mike's Hospital saying, we won't prescribe hydromorph. Why? Why won't you do that? You'll do methadone and Suboxone, and people are saying to you, that's not enough. People started using fentanyl because they wanted to cheat Suboxone and methadone. So let's be real about it. You could cheat your urine screens with fentanyl. It helped grow it in popularity, but people are using. And we don't have all of these supports for people like housing and income and all the things that make your life better. We don't have that to offer people, but they could offer people a prescription. They could offer people drugs so that people could use their money for other things, you know? And I'm just like so over it. I feel over it because so many of us, we put our own lives at risk for this fight. You know, it's affected people's relationships and their families. And there are other people with a lot of privilege who could do that too. So I'm just waiting for them to do that as well. Because like, I know there's a lot of compassionate people and there's a lot of people that we all work with, but the same dedicated people have been doing the same dedicated work for so long. And we need, if we want other people, we do need other people. We need other people to speak up about what's happening because, you know, we've done it. Like even with homelessness, I've been arrested so many times around homelessness stuff issues because, you know, it's not like the city created warming centers or 24-hour drop-in for women. No, it was people organizing that made them do that. They made them do it. They risked their own lives to do that. Getting arrested, even fingerprint, that's not fun. It sucks. It's harmful. But people did that so that they could get something that they know is just a Band-Aid solution for the real issue, which is housing and the need for housing. You know, we need a whole political system change that will actually care about people that are impacted by COVID and overdose and homelessness. We're not getting that right now, but we need to have those conversations with each other about what that political future looks like and how it is more equitable for everybody. Yeah, I'm pissed, man. I'm really pissed about the numbers. I'm really pissed about the lack of discussion. I'm really pissed to find out there's 1,100 unclaimed bodies in the province of Ontario, and a lot of those people are homeless and drug users. I'm pissed because people don't come back. Once people are dead, they're dead. And we're supposed to just sit here with our grieving hearts and just take it each time. No, I'm fucking angry. And I know other people are angry too. I'm not gonna sugarcoat it. The last 5 years have been hell. It is like being in a horror movie, watching a body come out of somewhere or seeing another body in the same week. That is a horror movie that we are living in.
So one question that I have is we're recognizing the extreme amount of trauma that people are facing, and there was, Gillian, I think you talked about an employee support program and things like that. So I'm curious, like from your perspective, what would a really good, robust wellness program look like for employees? Anybody can take that.
I think it's a really open question because I'm not sure that most of the supports that we've set up are actually adapted to the reality that we're in right now. And I'll give you an example of sometimes when I brought this issue up in organizations, people tell me that they have employment assistance programs that their staff can call into if they need support. But if you talk to staff members who have been on the front lines of the overdose crisis, who spend their days literally resuscitating people after overdoses, about what it's like to call an employee assistance program, they end up having the counselor on the other end of the phone who's supposed to be supporting them crying as they're describing the lived reality that they're going through. And so I think that we need to recognize that we need very, very specialized and adapted supports, that what we have developed and what we just generally offer to people is not enough. I think that this is going to look a lot like supporting community supports and supporting community members to support each other. But I think that for myself, as I've been looking into this, I come back to a lot of the work that the early AIDS activists were doing in supporting their own communities. I think that there's a lot of parallels there that we can take. And I think that there's a lot that we can learn from that generation of people who were also seeing huge amounts of deaths within their community with no government intervention, with governments not caring, in the face of huge amounts of social stigma, in the face of huge moralistic responses from family members and from communities. And so I think that we can learn a lot about how we can build mutual support for people. But one of the things that I keep coming back to is the fact that most of the people who are doing this support for each other are also completely burnt out. And so I'm really not sure how we do the work and take care of the workers at the same time. I don't think that we've developed really good ways of doing that. I think that we need to spend the time actually asking people what might work for them. And then we actually have to put in the money to building it. And this is where our current, the way that we fund our programs, our program structures is really, really a massive problem. Because as a researcher, I can go in, I can do research, I can document how awful things are for people. I can tell you what people are telling me are the responses that they think would be helpful. But then we need to synthesize all of that into somehow another grant proposal that will then in 6 months, we'll find out whether or not we've got this grant proposal to provide support to people that is available for people. And then it's a 1-year grant. And so we can only provide support to 1 year within the limits of this grant. I mean, the entire structure is set up for failure. The entire structure is set up to be short term. And this is not what is helpful or needed right now, because the last thing we all need is to be spending more time writing more grants. So to be honest with you, I don't really know what that looks like right now, but it doesn't look like anything we're currently doing.
I used to run a peer frontline worker support group for a few years, but then the issue was like what you were saying, Gillian, about like just being so burnt out. Like over time, it was just like really hard to keep it going because people kept dying like en masse, and then you just try to be there. And it was very hard for us to facilitate that ourselves, although it was a good idea. And it was like open to other people, like people working in food banks and like other places, for shelter workers who don't also get supports and are responding to lots of overdoses and deaths. And then I like been in contact with the Ontario Psychological Association because I saw that they were offering all this free therapy to people for COVID, and like contacted and had a conversation with them about how that would be really helpful for us. Like we really need some very experienced like trauma workers, like people who understand, like even people who maybe work with veterans, like people who understand, like, you know, if you've reversed hundreds of overdoses, and you know, like it is like fucked that people, you see people almost near death a lot, or maybe you responded to someone who's dead and like you have nowhere to, there's no one to talk to. Like you might debrief about that at work, but again, EAP is something community health centers have, and many of us have been saying for years that it doesn't work for us. You end up spending a lot of time teaching people about the drug war and doing a lot of educating of these workers instead of getting like the actual like support that you need in that moment. And it's very overlooked, and it's really unfortunate because I think it has led to a number of deaths of workers, and we can't ignore that. Like lots of workers have died, and there are workers who have now taken up using in particular ways that is also like impacting them just as they're trying to deal with this trauma. But I don't think, if anyone has who's like at this conference has like a really robust program that's about emotional health and trauma support and all of those, like, you know, I would love to know about it, because I think forever lots of us have asked for it. I know I personally spent a lot of money on therapists, and I always thought that should be free. You know, we shouldn't have had to do that, especially when you're talking about your job all the time.
I think for myself, things that I'm seeing in conversations with colleagues is that like I can use my frontline worker badge to skip the line at the grocery store, but I still don't have time to go to my own doctor. I don't have access to a doctor myself. You know, when I've had conversations with colleagues and with people who are working in the field, we really just would like some support around getting some of our own basic needs met. You know, like I have a home and I have access to some income and resources that way. But after working, you know, 10 or 12 hours that day, I don't always have the ability to make it to my doctor or to make myself a meal at times. Having some of those simple things that you can like connect over with colleagues and with folks, having a doctor come in, or someone who's a harm reduction therapist. If anyone in Ottawa knows a harm reduction therapist, like, holler at your girl, because I'm tired of my colleagues and my friends telling me that they go to therapy and they work with someone who then tells them, oh, it sounds like this field isn't for you. And it's actually not a personal or individual failing that I'm feeling the pressure, or I'm feeling the confounding factors and like immense grief and turmoil over this. It's actually a failing of all of the systems that continue to put people in terrible situations. And I think the other piece that comes to mind is that often harm reduction work is still precarious work. So you have folks who are casual, who are working more than full-time hours, who don't have benefits, who don't have access to those resources. And it feels difficult, I know, for a lot of people to take time off to recharge when you don't get paid for that day, and your income is also precarious, and you need to gather up those full-time hours to do what you need to do as well. So I think that there's a lot of things that we look at that I, like Gillian and Zoë have said, around what we think works for supporting workers, but these approaches need to be catered so specifically to harm reduction and so specifically to the work that's being done, because having EAP doesn't always make sense. It is a resource, but it might not do what it needs to do. And then it ends up being more traumatic and more tumultuous to try and talk to someone or talk to a stranger every time. So I think that we need to think a little bit outside of the box, and we need to talk to people and just ask, like, what do you need right now? And if someone says, like, I just need to come in and have, I don't know, breakfast here for me, then maybe that's something that we can do to relieve some of that burden for folks who are showing up to work, who are living with like active drug use as well, who are, whose own substance use is changing in the face of the pandemic. We really just need to ask what you need. And sometimes the simple things can really help folks and meet them where they're at.
Love that you said that, Callie, because like I think at our work too, like said, people were like making coffee for workers during the first lockdown, and people were like, we got free lunches, and there was like snacks, and they have like worker wellness stuff, but I haven't gone to it because it doesn't really fit like who I am. But I still was like, oh, that's so cool, like people have like stepped in to do this, but that never happened for us during this crisis that we've all been in for so long. And so that it like sharp distinction of that, it hurts. Actually, it does hurt, because you're like, we're in the same workplaces, and so you can see the impact on that on your coworkers. But yeah, I mean, I think those things that seem so simple, but like, yeah, making meals for people, or recognizing that a lot of coworkers don't have a lot of money, and just like having food. Like I had food in my office stashed away to give to people to take home, because I knew that people needed stuff, that they didn't have any money to buy stuff and stock up their cupboards like other people were able to do. So I got people to donate a lot of food and just stuck it in the cupboards, and then just like gave people bags of food. They didn't even know that was coming to them, because it is a lot. And cigarettes, like a lot of Indigenous people, elders were donating cigarettes, and we gave like those away to workers as well. So yeah, those things, those gestures can mean a lot. Actually, they can be so simple, but they can mean a lot to people. It just shows how much people actually care about their well-being too.
Again, reminder for folks, if you want to put a question into the Q&A, please do that. Seems like we're talking a lot about sustaining attention and commitment to these crises as they continue to unfold. And so I'm just wondering, Callie, thinking about the great program that you guys have going with the Cooking with a Cause, like how do you sustain some of the stuff that's working and that we've improved on because of COVID afterwards? Or is this all just going to go away when people go back to their normal lives, or their normal lives?
I think a big part for me that's been highlighted is the importance of a cross-sectional or like cross-sectorial approach to the things that we're facing. So when we're talking about food, this is only possible because we are talking to people in multiple different areas who may not have or may not have at times felt like allies, but really are. So like our local business association and local businesses and restaurants, Parkdale Food Center, like our food centers and places that really are now in the line of harm reduction. When we start talking about these things as harm reduction, we give people different language, I think, to describe some of the things that they're doing. This really it has an opportunity anyway to bring to the forefront that we need to work together to do this, to make an impact. And I don't know if this is something that can be maintained. It feels so difficult to be strategic in a crisis on top of a crisis on top of a crisis. So I'm very hopeful that this is a program, because of the way that it is. Also, it's palatable, I think, in a way, to talk about fostering local economy, to talk about that cycle of spending locally for restaurants and things like that. So when we look at food programs, I think that there are ways to capture the impact and talk about the broader impact and the ripple effect that people resonate with. And I think that COVID maybe has allowed us to be innovative. I don't know if once this is over, if people will still be interested or think that that providing meals to people in need is still a priority. That feels like a very negative kind of outlook, but I think that, you know, folks on the panel have already talked about the realities of banging the same drum and not really getting any sort of echo or any sort of response that's really making a change.
But Callie, I think it's a really, really important point, because I think that there's been a lot of movement and a lot of organizations that have done some really, really great work at getting COVID funding, COVID-related funding, either from the federal or provincial government, and target it towards areas of most need within harm reduction, within overdose response. I think the COVID recovery hotels that I was speaking about in my presentation, that was money that was set aside for COVID and for isolation for people that got turned into, okay, we need to make sure we have adequate harm reduction supports on site here. We need to make sure we have an overdose prevention site. So I think that there's been some recognition of how we can make that happen. But as to your point about whether this is sustainable or not, coming back to safer supply, there's a massive need for safer supply. The federal government had a program that funded 5 organizations across the country for safer supply. And then they freed up some extra funds due to COVID that in Ontario alone funded 3 additional programs, which is great. But they're funded until March 31st of 2021. In the midst of an overdose crisis that is unceasing. And so what happens to these people who you've brought into a safer supply program? You've gotten them stable on a pharmaceutical medication that is not the currently volatile drug supply they're getting from the street. What's going to happen to them on April 1st? Who is going to be funding that? Like, we are jumping from short-term funding package to short-term funding package to short-term funding package. And it is so destructive. We cannot do any kind of long-term capacity building. We cannot do any long-term program planning. It's always just trying to figure out how to play this shell game to move money around to the place of highest need and make it work. And we really, really need that integral sustained funding. And the fact of the matter is, we never had funding for harm reduction, period, in Ontario until 2017 because of the overdose crisis. Prior to that, all harm reduction programming was funded through either HIV or hepatitis C envelopes of funding. We never had harm reduction funding as a standalone. And that's only come about so recently, but to deal with the newest crisis. And again, it's not being done in a sustainable way. It's not being done in a long-term vision of how we can really, really build strong programs and strong communities that can have long-term response to these issues. And that's a major, major issue. And I don't know how to get around it either.
And that speaks to like when to like political bodies say, you know, okay, we've got to do so, like City of Toronto. It's like, okay, we're going to ask the province and feds for something, but then we're not going to actually fund anything ourselves. Or like the federal government who says, we'll give you an exemption for your SES, but we actually won't fund it. So Saskatchewan are out there with like selling t-shirts to fund a safe injection site. But that is where the federal government need to invest, because there is so much hatred for harm reduction and hostility in a lot of provinces and territories. And yet that's like when the federal government says, okay, we'll give you this exemption, then cough up the money and make sure that it's long-term. I know that HIV, like right now, HIV organizations are waiting for their funding. Like I think it's like $125 million. We cannot operate this way. It is not sustainable. It is very stressful to operate this way. And that is what we need to ask for and be demanding for in the future long game, is that we can't work, contract to contract. This is why we have a whole host of employees that don't get benefits, because we don't know if the money's going to come. So we'll say you get a job for 7 months, you can have this contract for a year, but without sustainable funding for what we know works, then this will continue to be like this. And so we can get all the therapy we want, but then the people really just need like some days off and aren't taking them,
March 31st seems to be like this magical day across the board. I don't know of any funding that goes beyond March 31st for any pot that we've seen, and we know that a pillar of trauma-informed care is consistency. And what we're seeing is that we are just traumatized over and over again by funding being pulled away, by more people losing their lives because of the way that this has been structured. And it's just, it's violent.
Okay, thank you, everyone. I'm not seeing more questions in the Q&A. I'm wondering if anybody has any kind of final remarks or anything that they have not said at this point. I appreciate the comments have been very frank and very very visceral. So, but just to give you an opportunity before we sign off, if there's anything else.
I don't know who's like actually in the audience watching, which is like the weird thing about doing these things. I can't see you if you're there. But if you are someone that works in bureaucracy or for like, the federal government, the provincial government, or your local government, you can't ignore this. And, I think ignoring it and not like investing makes you complicit in the deaths of people. And I think that's not, it's not what I know that it's not what people want, but it is actually what is happening. And I don't want to have the prediction of Ontario that we are going to have 2,271 deaths. Nobody wants that, but it does take some, it's not even courage, actually. It's not courage to speak up. You just have to do it. It's not courage to put your neck out. You just have to actually just do it. There's lots of people who take risks. And so I think there's people sitting at levels, and I know people do it. I know people are trying, but how hard are we actually trying? How hard are you actually trying? And so that's what I would say to decision makers or people who have access to people who make these decisions, the funding decisions, is like, at some point, you might have to take a bigger risk, because lots of us have. Those risks come at many costs. But at the end of the day, those risks could save a lot of people's lives. And that, I think, is what a lot of us want to see.